session for today. So we will start off by going through a little bit of epidemiology and just kind of a landscape of HIV in Australia and in WA. We'll then do an overview of HIV, so we'll look at how it works in the body, and then we'll look at treatment and prevention options around that and transmission. So there we go, treatment, transmission. We'll then do a bit of a deep dive into testing. We're looking at, so then we're looking at like serology results and also the other things that come with testing as well, like delivering a positive result and referrals and contact tracing and all that fun stuff as well. And then we'll end on talking about prevention. You will also receive, after this, I will email out the link or the recording of the session. You will also receive some resources I'll send through to, and I'm hoping to get to have a PDF copy of these slides as well. So if there are any referrals or services or information that you wanted to access, you will be able to do so afterwards when I send through the slides. So to start off, we'll look at kind of HIV in Australia. So most of this data is from Health Equity Matters. So that is previously were, oh my gosh, I've just blanked on previous name for Health Equity Matters. FAO. So it's kind of the overarching body across Australia with kind of like the umbrella kind of organisation with the AIDS councils across Australia. So we sit underneath them. So they release a report every year that kind of summarises HIV in Australia. So this is from the most recent one. So at the end of 2023, there's approximately 30,010 people living with HIV in Australia. You can see here the cascade around treatment of HIV. This is a measure that's used globally, tracking towards virtual elimination of HIV, but also so that we can see how we're progressing in the areas of treatment, effective treatment, and also testing as well. So in Australia-wide at the end of 2023, 92% of people living with HIV knew their status. So they had been tested and found that they were positive. 97% of those people who knew their status were receiving treatment. And then of those receiving treatment, 98% of those people had an undetectable viral load. So we'll get into a little bit more what that means in a moment. But you can, these are really kind of good metric that is used to see how we're kind of tracking globally towards virtual elimination. The aim originally was that we had 90% in each of these categories. Now it's been up to 95%. So the aim is to get to that by 2030. You can see here as well, we're looking at HIV transmission in Australia. This is from 2022, and the main kind of identified modes of transmission, population transmission there as well. And then just down the bottom, you can see, so 2024, we had a little bit of an increase in WA of HIV notifications. During COVID, as we'd expect, we saw a lot of other infections as well, a lot of other STIs. There was a bit of a decrease in the notifications. With decreased mobility and overseas acquisition and travel. We've seen now kind of returning to pre-COVID levels, and between 2023 and 2024 there was a little bit of an increase again. In terms of the population, so we're seeing kind of a bit more of higher increases and kind of the higher test positivity rates. We're seeing more so in males, both through men who have sex with men exposure and also through heterosexual exposure as well. And also overseas acquisition of HIV as well, for both males and females as well. So that is just a brief little epi update. If you want to find out more, I will send through the link as well to that overview sheet that HEM release every year. Just very quickly though, before we get into the overview of HIV, I really want to start off with focusing on language. So historically, and still to this day as well, there is a lot of stigma that is around HIV. And that's a combination of obviously the historic kind of implications of what happened with HIV through the 80s and 90s, and also the general kind of rhetoric in general community. And a lot of those kind of misinformation and a lot of kind of harmful information and language is still out there. So one way that we really encourage that we can start to address that stigma in both in our professional practice, but also in our daily lives as well, is how we use the language and how we talk about people and talk about HIV. So we've got some examples here, and you'll hear us using this language throughout the presentation today, but using the term person living with HIV, person-first language is really important. So we're not wanting to define somebody just by a health condition that they have or particular behaviour they're engaged in. They are a person first, and people have complex needs and other things going on in their lives. They're not just defined by the one thing that we may think is kind of a priority, or one thing that's happening in their life, such as a behaviour or a health condition. So similarly there as well, so a person who uses or a person who injects drugs. When we're talking about where risk with communities and behaviours, we're talking about a risk being with a behaviour, not with a group. So just because somebody belongs to a particular population, a particular cohort, it doesn't necessarily mean that they have a higher risk just by by default being in that community or that cohort. We're talking about the risk is with behaviour. And we're talking about communities that may be affected or kind of disproportionately affected by notifications or by things such as HIV. When we're talking about sex, we're talking about protected, unprotected versus protected sex. Instead of using the term risky has, again, it's a lot of stigma associated with the term risky, and also it's quite vague as well. So what we were talking about here, we want to be naming the behaviours that we are talking about, so unprotected sex, or sex without a condom. Using the term normal sex, particularly we hear this a lot with young people as well, kind of normal sex. If you ask a whole bunch of individuals what they define as normal sex, it would be completely different. So we're talking about particular sexual activities, so vaginal sex, anal sex, naming that specific type of sex. And then also when we're talking about things like needles and injecting equipment, using the terms used or sterile, as opposed to something like dirty and clean, which is quite very stigmatizing and quite negative, and have kind of language there as well. So when we're using these we're being kind of mindful of this language, and we can kind of get used to the habit of using person first language, and kind of reframing how we talk about communities and we talk about different behaviours, we can really start to kind of address a bit of that stigma around how we talk about HIV and understand HIV in our communities. So very briefly go through a bit of an overview of HIV. So HIV stands for human immunodeficiency virus. So first and foremost, it's a virus that exists within humans and requires a human body in order to be able to survive and to replicate. And immunodeficiency, so what it does is it depletes or affects the immune system and damages the immune system. Another term as well that is very commonly associated with HIV is the term AIDS. We like to differentiate between the two. They are not interchangeable or the same thing. Today we'll be talking about HIV. We're talking about the virus that's transmitted between people. That's what's treated, that's what's prevented, and that is again what passes between people. AIDS is a possible outcome with HIV existing in the body for a prolonged period of time. So with AIDS, we're talking about acquired immune deficiency syndrome. So we'll look at how the kind of interlink between the two in a moment. Won't spend too much time on this. I know that sometimes all these kind of nerdy looking at diagrams may not be for everybody, but very just briefly kind of explaining how HIV works in the body. So this is without any kind of treatment. This is the natural kind of lifestyle or replication cycle of HIV particles in the body. So what happens is they'll enter into a point in the body, whether that's through a cut, whether that's through mucous membrane, enter into the body, and it'll come into contact with CD4 cells. So in order to be able to replicate, they require, HIV particles aren't able to do so on their own. They require a host cell in order to do that. And the cells that they attack are the CD4 positive cells. So these are really important components of our immune system. So they help to both, to regulate and to stimulate immune responses in our body. So what it will do is it's attracted to these CD4 cells, it binds into them and undergoes a process called reverse transcription. At this point there, it's able to create its own little version of viral DNA and insert itself into the genetic makeup of that CD4 cell. As that CD4 cell continues to replicate in its regular replication cycle, it will then start to churn out these HIV particles. So it'll create more copies of this viral DNA, and then is then able to go through the process to have a mature HIV particle released. These new HIV particles will then go onto other CD4 cells and continue the same process. This happens very rapidly, and there is particularly at reverse transcription. So there's different enzymes involved in this, and looking at this helps us to kind of explain how treatment works in a moment, and also prevention like PrEP works as well. So the way that HIV replicates is it replicates very, very rapidly, and it also is quite prone to mutations as well. So we'll get into as well a bit more in a moment when we're looking at treatment, why treatment adherence is really important and why we use 2 drug regimens for HIV treatment. So there's kind of three kind of key terms that I want to kind of get everyone to kind of keep in their minds when we're talking about HIV. The first one is CD4 cell count. So what we're looking at here is the measure of how many CD4 cells there are per cubic milliliter of blood. So we're looking here at, I guess, the strength and the health of the immune system. Then when we're looking at the viral load, we're looking at how much HIV is in the body. So we're looking at obviously it coincides there with the effect it's having on the body and how much of the suppression or effects it is having on the immune system. But also this can be used to measure the effectiveness of treatment as well. And when we're talking about both CD4 cell count and viral load, there's a really important number, 200, which we like to look at when we talk about, I guess, the effects of HIV on the body, and then also the effectiveness of treatment as well, which we'll get into. Take a breath for a second. Anything you want to add to that?
No, you don't know.
Alrighty, so this is a little diagram we like to use to kind of explain what's kind of going on over a long period of time with HIV in the body. So the first point there is the point of transmission. So the CD4 cell count that we would expect to be, it's going to have a healthy CD4 cell count range. We've got there, so between 550 to 1400. And obviously prior to transmission, there'd be no HIV in the body. We then enter into what's called the acute phase. So this is characterized by a really quite high or rising viral load, and it occurs really rapidly as well. So we can see here, obviously going from no HIV in the body to then possibly up to over 1 million copies. And this happens in quite a short period of time. So the acute phase can go anywhere between 2 to 12 weeks. Less than 12 weeks, there we go. So then there gets to a point where the body then starts to mount a immune response. And the body's not able to clear HIV entirely from the body, but is able to kind of sidestep the mechanisms that HIV is using to affecting the CD4 cells to start to suppress the CD4 replication and to kind of restore those CD4 cells as well. We're not able to get back up to the healthy count or that count that we would have prior to transmission, but there would the body does start to mount some form of immune response. This is called seroconversion. At this point, somebody may experience symptoms. So kind of viral-like symptoms, sometimes described as being glandular fever-like symptoms. And this could be 2 to 6 weeks after, after the acute phase, after infection. So that could be characterized by things like headaches, being lethargic, inflamed lymph nodes, rashes, kind of, again, there's glandular fever-like symptoms. Not everybody may have these or may recognize them as not maybe as kind of clearly defined as being strictly just HIV. They are kind of symptoms. They are quite, and they can occur in kind of different kind of degrees as well. Did you want to add anything?
Yeah, so seroconversive illness is not guaranteed with HIV infection. Often it may just feel like a mild cold or flu or nothing worth mentioning at all. So it can just be completely asymptomatic also.
So after that occurs, the person will enter into what we call the asymptomatic phase. So we've got here, this can be between 10 to 12 years. This kind of time frame is kind of an estimate and assumes access to healthcare and other without other kind of existing health conditions as well that may impact the immune system, and again, access to healthcare services as well. So this can vary depending on the setting as well. So at this point here, so somebody again will have a bit more of a suppressed immune system as well. Still possible to transmit HIV in this period too, and it may be characterised by they may be getting unwell more regularly. So things you kind of expect with having a slightly more suppressed immune system in this time. This is where the number 200 comes in as well. So again, we're talking about HIV without any treatment. So after a period of time, as the HIV continues to replicate in the body and the CD4 cell count is able to kind of sustain itself, or the immune system is able to sustain itself ongoing without support. So it is possible then for somebody to develop AIDS or the acquired immune deficiency syndrome. So one of the criteria for an AIDS diagnosis is a CD4 cell count of 200 or below. And also the presence of sometimes they're called AIDS-defining illnesses or an opportunistic infection. So these are infections that aren't normally kind of seen in the general population and come about because of that kind of prolonged suppressed immune system. So this is where kind of treatment comes into it as well. So remembering that kind of going through that life cycle, where there is really effective treatment available for HIV. There's many different options as well, and it can mean taking 1 pill a day or even an injection every 2 months. So kind of gone are the times where it was handfuls of pills multiple times a day. There is really, really effective treatment and different types of treatment available too. So these are managed by S100 prescribers, and there's kind of different combinations that somebody may take. So commonly it is, well, it has to be at least a 2-drug regimen. So there's many different types of drugs that will affect, will kind of interrupt the HIV life cycle at different points. But what I was saying, as I was saying earlier, as HIV replicates, it is very prone to mutations. So it's quite tricky in the sense that it does it has have quite an affinity to developing resistance to treatment. So it's quite important. So that's why at least a 2-drug regimen is used to be able to interrupt that life cycle at different points. It's also why medication adherence is really important as well. If somebody has interruptions or disruptions to their treatment, it really increases the likelihood of developing resistance to that particular medication, which means that somebody would then need to be changed to a different type of medication that's determined, worked out with the S100 prescriber. But obviously what we want to be preventing that, encouraging or enabling and helping people to be able to take their treatment and avoiding these kind of interruptions and disruptions, so that we're not kind of limiting the amount of treatment options available. So you can see here, so there's can interrupt at any of these kind of points here, and there's big charts you can go onto with the different manufacturers of these medications. You can look a little bit more into that if that is of interest to you. So there's, again, many different types of treatments. Some of it may just taking 1 pill a day. There is also long-acting intramuscular injections as well, which is called the Cabenuva injection. So what this is an injection every 2 months. It's two injections every 2 months, so 1 in each butt cheek. So again, we're having that kind of 2-dose regimen there, and that's every 2 months. So that doesn't require taking a daily pill. That's somebody who's able to get that done in 2 months. There's a little bit of a lead-in period, so it's 1 month and then another month, and then so it's 1 month, and then off again.
Yes, correct. Yeah.
But that is another option as well. If maybe taking a daily pill is not suitable, some people may not want the reminder you're taking a pill every day, or maybe it's hard to take the pill at the same time every day as well. So that is another option that's available, which is amazing. HIV treatment in WA is free, regardless if people have Medicare or not. Always, it can be accessed for free, regardless if somebody is Medicare eligible or not. So that's through hospital pharmacies. So if somebody isn't eligible for Medicare, they can go through hospital pharmacies and able to access treatment that way. You can also, if somebody is going through a private GP, an S100 prescriber at their local GP clinic, for instance, they can access the treatment as well through their local pharmacy, and also some online pharmacies too. So the cost is more, any kind of costs would be through their consultations and seeing a private practitioner if they are charging, not bulk billing. So just coming back to just kind of rounding up there, we're looking at treatment. So coming back to, we were looking at what the kind of long-term kind of life cycle is, or long-term effects of HIV on the body. So if we were to introduce treatment, we can see how this looks now. So again, transmission occurs, goes through the acute phase. Let's go back. And then so you can see at this point here that somebody has gotten tested and then found out that they're HIV positive and has started taking treatment. And at that point there, what happens is, as the CD4 cell is protected and we're preventing that, interrupting that kind of HIV life cycle, the HIV replication rapidly decreases. Again, we're still not able to clear HIV from the body, but we can get it down to really, really low levels, and to the point where it can be undetectable levels within our tests as well. At this point there, the body is able to kind of regenerate and sustain its CD4 cell count and immune system, and able to live a long, healthy life. We encourage people to start obviously testing regularly and to start treatment as soon as possible. So the treatment is effective at any kind of point, no matter how low the CD4 cell count is or how high the HIV viral load is. But the only things that it isn't able to reverse is if there's any of those kind of opportunistic infections that may come up from having that suppressed immune system. So that will require obviously other kind of medical intervention there as well.
And just to know, with the treatments that we have available these days, the Whoever the person living with HIV, once they start treatment, about a month later often is when they'll reach the undetectable viral load. But officially, they're determined undetectable if they maintain that for 6 months with testing. Yeah.
Perfect segue there. Yeah. So you may have heard the term U equals U or undetectable equals untransmittable. So when we're talking about here, like what Peter was saying there, when we're looking at viral loads, and again, that number 200. So we're talking about 200 with a viral load. If somebody's viral load is 200 or below, an individual's HIV status can be considered to be undetectable. We know that we can detect it down with the technology that we have available in the test that we use in WA. We can detect it to a lower level, lower than this, but we kind of use that 200 as that kind of effective point for it to be untransmittable. So at this point here, where there's a viral load of 200 or below, there is no risk for HIV to be passed on during sex. Research has also demonstrated that it is really, really effective at preventing transmission through other behaviours like sharing injecting equipment, breastfeeding as well, and pregnancy and childbirth. Most of the research that is able to kind of confidently say that without any doubt say that it can't be transmitted through sex. That's where most of the research is. There just still isn't, I guess, enough evidence for them to say 100% that it prevents transmission through other forms. Why is the computer ringing? But it is still highly effective at reducing risk of transmission. Oh, we have another computer that's ringing. That's what we put to deemed to be U equals U. That's going to go on to transmission as well. So you may be familiar with this formula. It's often used to describe or kind of to talk about the transmission risk with bloodborne viruses. So I know hepatitis WA use a very similar formula when talking about the transmission of viral hepatitis. But looking at where risk possibly could be for HIV transmission. So there's many kind of criteria for to be ticked off in order for there to be a risk of HIV transmission. And this is kind of a good thing for us to understand, both working in healthcare and also as part of the general community as well, where a lot of the kind of fears that lead to a lot of stigma and discrimination often are around that I'm not too sure where the risk is, or is there a risk, kind of the perception that there is really high risk for things like hugging and different things like that, interacting with people living with HIV when we know that there isn't. So it's good kind of way to kind of myth bust when we go through the transmission. So I'm running a little bit behind, so I don't want to. All good. So different ways that we can get I don't know what's going on the slide here. So ways that HIV can be passed on. The first one we're looking at is that virus being present. So again, we're talking about the virus being present in the body. Obviously, we can't transmit HIV if somebody doesn't have HIV, but also the virus is at a high enough viral load for it to be transmissible. So if somebody is engaging in unprotected sex, but they have an undetectable viral load, we would say that there wouldn't be enough of the virus to transmit, and that there would be a risk, that there isn't a risk there. Then there's only particular body fluids that have a risk of transmitting HIV. So they can be passed on through contact with blood, and that also includes menstrual blood as well, semen, pre-ejaculate fluids, vaginal fluids, anal fluids, and breast milk. So there are other body fluids that contain very trace amounts of HIV, but it's not enough to be able to transmit HIV. So there's only particular fluids that actually have a risk of transmitting it. These ways that these can pass on, so looking at behaviours. We then look at behaviours, well, where can somebody come into contact with these bodily fluids? Kind of the common or higher kind of risk behaviours, or the common behaviours associated with HIV transmission, looking at sex without condoms, so vaginal sex and anal sex, sharing injecting equipment, so needles, syringes, also other injecting equipment that may have blood or all these bodily fluids on them, so things like tourniquets, the vials and things like that as well. So the carrying parent to baby, so that kind of transmission to the baby, that could be through pregnancy, birth, or breastfeeding. Things like sharing razors and other kind of cutting equipment, piercing or tattooing equipment. And then also having these body fluids getting into cuts, mouth, eyes, things like that. Where the risk is when we're talking about these are looking at kind of the relative kind of risk without any kind of intervention. So without ART and without having an undetectable viral load, not using things like condoms through sexual contact. You can see here where there are higher risks. I put a little asterisk there for, I'm not going to go through every single one here, but put a little asterisk there when talking about insertive anal intercourse. So the risk for insertive sex, so being the insertive partner, so the person inserting, during sex versus the person who is receiving, and there is a different risk considered both for anal sex and also for vaginal sex as well. Interesting as well, there is quite a bit of evidence, or growing evidence, that suggests that there is, for the insertive partner for anal sex or for sex, that if the insertive partner is circumcised, it actually greatly reduces the risk of transmission. So that's of interest to anyone to looking into a bit more. There's a lot of growing evidence in that area to suggest that does quite greatly reduce the risk of acquiring HIV. And see here as well the other behaviours there too. Again, we're talking about sex here without condoms and without having an undetectable viral load as well. Cool. Alrighty. Well, that's enough from me for a little bit. Now hand over to Peter to look at HIV testing.
Okay, so testing we have available, basically two sorts. Is the basic, you go to your doctor, sexual health clinic, and you get a blood draw, and screening test would be a serology, which is looking for antibody antigen testing, basically. You've got a window period up to 6 weeks, which is important to tell the testee, that if they had unprotected sex risk within the past 6 weeks, this test result is not definitive, so they will need to do another test after that 6-week period is used up. A lot of the information online and maybe given elsewhere would say up to 12 weeks, so 3 months after risk. In most cases, 6 weeks is fine, but 12 weeks if they've been on, say, post-exposure prophylaxis or potentially on other immunosuppressing medication would be advisable to do. Then there is the rapid test, so finger prick blood test, which Tomo is I think the only one currently approved by the TGA in Australia. It's available through WAAC, Clinic, and also some 777 pharmacies. Correct, yeah. And you can also get it for free online through some method.
I can send it out. Yeah, it's a national program that people can get them delivered out to them.
Yes, and quick test similar to well, it's the same setup as COVID testing, except it's using blood. It's all self-contained, needle is part of the package, and finger prick after 15 minutes later, you get a result. This one, 12 weeks is the window period, so good to have because it's got a quick turnaround, whereas the blood draw may take a couple of days to get a result. So yeah, that's basically for the standard testing. So what we do normally before testing, if they come to, for example, the clinic, we just determine what behaviours they've been going through in the last, say, since the last test or in the last 3 to 6 months, get a bit of a history, who they have sex with, what kind of sex they have, travel, symptoms, medications, uses, all completely non-judgmental, of course, and take this test, recommend further testing if needed. Majority of our clients are MSM, so technically a high-risk cohort. So HIV testing just included as standard, unless they choose not to get that tested for whatever reason. I know a lot, some GP practices are bringing in opt-out testing for HIV and syphilis, which should always come together. But yeah, that's something else to do some investigation into. So as well as the HIV testing, we are checking, of course, other STIs, syphilis, gonorrhea, chlamydia, hepatitis B, C, A, if needed, and TB testing for people coming in from overseas, from TB endemic areas. What else could you test? So basically, we're looking at behaviours when we're testing for HIV. It's kind of hard for me to determine because everyone who comes here gets one mostly. But in the general community, if they're having sex, good to do a HIV test just to get a baseline. Ideally, it's negative. Most of the time it is. And then if any new partners come along or they've had unprotected sex in the last 3 months, good to get a HIV test just to confirm negativity. Yeah, go on.
Cool. That is a positive result.
So these don't come up too often. And if you ever test someone and they do come up with HIV detected, you will get a phone call from the micro-reg at usually Path West before you get the report through. So the main test is serology, so HIV 1-2 testing. Will come up reactive. They will do a confirmatory test to confirm, because there is also the chance of a false positive. And if that's reactive as well, then they'll do another confirmatory test through PCR or Western blot. Path West have recently changed in the last, say, 6 to 12 months from the Western blot as a confirmatory test to PCR. So this is a bit of an older test on the right. So the left, yeah, serology, reactive, and then confirmatory on that is reactive too. Then they'll do the other confirmatory test if the Western blot is showing positive result, or PCR as it is now. That's the next one. That's PCR, the NAT test on the right. So if that's reactive, and then yeah, confirmed HIV. If you get that call from the micro-reg at the lab, they will then talk about taking another blood sample to do another confirmatory test, just because there have been instances in the past where samples get mixed up, and they might just confirm that it is the right person that you have that has the positive result. And then we move on. So once someone has been determined to have HIV, they'll be then coming to get checked by the doctor, the nurse, who will then do that confirmatory test, serology again, and then all the other tests to commence on treatment. This test is the PCR testing, or it's the viral load testing, basically. On the left, we have a result from just their first, I suppose, appointment with the doctor to start on treatment. So the day they get the script to start treatment, viral load is 117,000. And then, as you can see, just over about 5 to 6 weeks later, it's down to under 200 copies. So they got started on treatment, started within a day or two of that first test, and have been taking it for 5 to 6 weeks, and it's already down to under 200, so basically undetectable. So medication works. All of it works now. Like, the main issue is just talking about side effects and growing old with HIV these days. And along with this viral load testing, we're checking CD4, which will be the next slide, and checking on their initial CD4 levels. A bit low there, 23, but 700 absolute count, so it's not too bad. And then that will slowly creep up as they stay on their treatment over time. It can take, years potentially to get back to sort of a normal range, but that's one of the monitoring tests. So the main monitoring tests for people living with HIV would be the viral load and the CD4 count, as well as all the general health sort of testing, and checking for other things that may present opportunistic infections, but that's not what we're here about today. And as well as starting on medication, there's the whole sort of social support and mental health support that can be linked in at that time. Referrals to places such as WAAC, who can provide peer support and counselling, and caseworkers, to other positive organisations such as NAPWA and POWER. And also, like, at the top, you've got the treatment places in WA. The main hospital would be Royal Perth. They have a large cohort through their immunology department. I think it's around 2,000 from last time I heard. Fiona Stanley, and also, Royal Perth also cover most of the regional northern area as well. Fiona Stanley have a large cohort as well, not as much as Royal Perth, but they also cover the southwest too. And then Sir Charles Gardner Hospital, their HIV clinic is fairly new, but they mostly focus on the northern west suburb of the metro area. And then a few of the main GP practices in Perth, GP on Beaufort and View Street Medical, have several S100 providers there who have quite a few patients living with HIV too. And us at the M Clinic, though one of our doctors does treat HIV. We're a fairly small cohort, but we are going to be starting to help with the Cabenuva injections here soon. Exactly.
Yeah.
Talk about the other organisations.
Well, I was just going to say it's we really want to look at as well. This can be something that you could turn to prior to delivering a positive result. So say if you are the one delivering the positive result, so one for kind of supports and linkages to care there, like I was saying before, it is for treatment, it is important that we get somebody linked to care and on treatment as soon as possible. And obviously that needs to be managed with an S100 prescriber. So whether that's through one of the public hospitals, the immunology departments, or if it's through a private clinic or GP clinic where there's an S100 prescriber there, we want to get that linkage to care happening as soon as possible, and that kind of care team formed. But obviously a part of that as well, there are other kind of supports too. So when you are talking to a person, their initial needs may not be to, it gets to be monitoring kind of what somebody's initial needs are, what they want to know, and to where we kind of support them as well. We can leave in kind of high and dry. There are many other social supports as well that somebody may be able to lean on, particularly kind of after initially receiving a diagnosis, talking to peers such as our incredible peer support workers at WAAC, to kind of work through kind of what that kind of looks like, what's treatment going to look like, am I going to be okay answering those questions and those concerns that somebody might have. And of course there are other positive organisations too. There's a really great resource that NAPWA has on their website that goes through this quite in depth if you are a clinician that is delivering a positive result. It's kind of like a little module that you can go through and really kind of talks about how we can really address the needs and being there for the person as well, and giving a really kind of personable kind of experience for, and you're not trying to be too disconnected or from the person when delivering, could be quite big news for them. So these are some different kind of services that you can go to. I always recommend if you aren't sure who you can kind of refer through to, you always can call WAAC and speak to the incredible social support services team there, and link people into care that way as well. And just people as well knowing that they have got these options available. So the peer work is, they are based in Perth, but they can also converse over the phone with anybody statewide. Fun stuff.
Yeah, so HIV, like a lot of other infectious diseases, needs a notification to be sent to public health. And as part of that process, you have to talk about contact tracing with the person now living with HIV, which may take a few weeks. It's not sort of is and isn't an urgent process. It's best to take it as they are able to take it, and they may want to do their own contact tracing if they're quite, I guess, happy to. And we like whoever, so it can be person to person, the clinician who diagnoses can help assist with that process, getting information, numbers, email addresses from the patient, and then sending out either anonymously or just saying, you're a known contact of HIV, go get testing. You can seek support from the public health unit, pop health unit. And there's also a new peer contact tracing program, which you would know maybe more about.
Yeah, but it's a new pilot project that's being run by Health Equity Matters, so it's nationwide. And essentially how it works is that for somebody receiving positive diagnosis, that they can be linked in with through the clinician, can be linked in with the team of peer contact tracers. So these are people living with HIV that are able to help and assist with a process of contact tracing. So they can, I believe that they can choose which peer that they would like to work with. So they can opt for somebody that's not based in WA if they are worried about people finding out and kind of the confidentiality side. If they have a preference around somebody's age or somebody's gender, that they are able to kind of select based on that as well, or kind of put in a preference as well. It is still a pilot project, and it's only just kind of starting. Some of our incredible peer workers at WAAC have been kind of involved in the different kind of peer organisations as well around Australia. So if you want to know a little bit more about that, you are welcome to reach out to us and we can direct you through with some more information on that.
Okay. What's next?
Cool. So lastly, we're just going to talk about HIV prevention. So this is kind of messaging as well more broadly around kind of STI prevention too, bloodborne virus prevention. that we can share with more general community, or maybe if we're seeing people in kind of a clinical setting as well. So one of the really effective ways of preventing HIV transmission through sex is using condoms. So highly effective at preventing HIV and the transmission of other STIs as well. Covering up things like cuts if somebody possibly could be exposed to those bodily fluids we were talking about earlier. Taking treatment, so taking HIV treatment, so we call this treatment as prevention. So like we were saying earlier, if somebody has an undetectable viral load, it can't be transmitted on to other people through sex, and it greatly reduces the risk of transmission through other behaviours as well. Not sharing things like injecting equipment as well, using sterile injecting equipment as well. So again, those needles, syringes and other injecting equipment too is really important for wanting to prevent both HIV transmission and also transmission of other bloodborne viruses like hepatitis C. And having the conversation, so encouraging people to talk more about it as well. When was your last test? When are you on PrEP or PEP, which we'll talk about in a second. Having these conversations with sexual partners or with people that you're with as well is really effective as well to have the conversation, encouraging prevention too. And really incredible, we have these things called PrEP and PEP. So these are pharmaceutical forms of prevention, really highly effective forms of HIV prevention. So PrEP is pre-exposure prophylaxis. So essentially what it is it's prevention for people who do not have HIV, and it's really important. So when somebody is going on to PrEP, they will be tested for HIV because what it uses is two drugs that are very similar kind of drug combinations to what is used in ART or in antiretroviral treatment for HIV. So it is used at different kind of doses as well. So we want to make sure as well that it's only suitable for prevention, these doses and these combinations, and not for treatment. So we don't want to be introducing kind of treatment to somebody's body if they do have HIV and possibly run the risk of something like kind of resistance. That's the word. I was like, I'm dancing around, can't think of the word. So it's taken before potential exposure, hence pre. It's 99% effective for receptive anal sex. So before, when we were saying about the kind of the behaviours and the highest risk of the different sexual contact was with receptive anal sex. So it's highly, highly effective at preventing HIV transmission across behaviours there. But here you can see, again, it interrupts that HIV life cycle. So if HIV was to enter into the body, that's essentially the CD4 cells are protected from HIV being able to replicate successfully. And hence not being able to uptake in the body. So it's available in different dosing regimens. So one of the more common ways for PrEP to be taken that is available for everybody is taking it as a daily pill. So one pill once a day. Again, this is available for everybody to take, and it is different lead-in times depending on somebody's gender. So sometimes, for a lot of people, it is a 7-day lead-in. For cis men, particularly men who have sex with men, they can have a shorter lead-in time as well, which leads to PrEP on demand. So sometimes it's called event-based PrEP, PrEP on demand. There's a few different terms for it. Essentially what this is kind of a shortened or kind of more, I guess, able to kind of pick and choose when wanting to take PrEP, not requiring to take a daily pill every single day for prevention. You can do it in the lead up to an event or maybe going on holiday, something like that, a shorter lead-in time. So there's 2 PrEP pills between 2 to 24 hours before sex, and then taking 1 pill 24 hours after the first dose, and then again 24 hours after that, and then or after kind of it's easy to look at the diagram there. So again, but this is only recommended for cisgender men who have sex with other men. Reason for that is, again, there's more evidence in that area than with other people as well. That is to do with kind of how PrEP uptakes in the tissues in the body as well, and how hormones affect it as well. So for everybody, or anybody is able to take daily PrEP, but there is also PrEP on demand as another option too. PrEP can be accessed a number of different ways. So it does require a prescription, but it's not an S100 scheduled drug. It can be prescribed by any GP, nurse practitioner, sexual health clinic. Requires a HIV test. They do test for kidney function as well, just as it's a very kind of low risk for causing kind of renal issues, but it has been evidence there like some slight risks. So they do like to monitor that as well, and also general STI screening. And then again, regular kind of contact with a clinician as well throughout the course of using it. It is on the PBS, so it's available full cost. I think it's $31.60 last time I checked per month. If somebody has a concession card on the Closing the Gap scheme as well, it is subsidised further. For people that aren't able to access the PBS, so particularly for people that aren't Medicare eligible, there is also other ways that it can be imported too. So they still does require PrEP prescription, but it can be imported through overseas pharmacies, which may end up being cheaper than paying the full price without that PBS subsidy in Australia.
So the private cost of PrEP these days can be, depending where you go, about the same cost as the PBS price. It could be $25 to $30 per month.
I want to find out where that is. Yeah.
Usually Chemist Warehouse.
Chemist Warehouse. Yeah, true. They like good old Chemist Warehouse. Anything else you want to add for PrEP? No. And then we also have PEP. So this is a post-exposure prophylaxis. So again, it's looking at that. So predominantly is a 2-drug regimen. So often it is the same exact same drug that's used for PrEP. And what it is a medication that's taken after a potential exposure. So it's over 80% effective at preventing HIV transmission. So again, this is after an event where HIV is possibly entered into the body and helps prevent that HIV replication in the body and protecting those CD4 cells. It must be started within 72 hours. So the sooner it's started, the better. And it's taken for 28 days. So commonly it is that 2-drug regimen, so the same as PrEP. So you may hear the term kind of PrEP as PEP. But there is also in some instances where a 3-drug regimen may be required there. PrEP, there's a few different places, ways that PrEP can be accessed, also PEP can be accessed. So it is free through hospital pharmacies and emergency departments as well. You can also get prescriptions as well from GP, sexual health clinics as well. If somebody isn't too sure where they can access PEP from, there is an info line that they can call or a website that has got a map that they can look at. It's called getpep.info and be able to find out where they can access it or they can talk them through it too. There has been some people having experiences going to emergency departments where they not necessarily been denied it, but they sometimes the staff there aren't aware that PEP is available. And so they're able to, if they're able to call the phone line, they can kind of talk through the process. And if there's an on-call immunologist and explain that it should be hopefully available for them through the hospital pharmacy, the emergency department there as well.
So if they do go to a GP wanting PEP, they would have to get it prescribed as PrEP, as PEP is not under Medicare or PBS, sorry. But yeah, it can be prescribed as PrEP, yeah.
It's only relatively recent thing in the last couple of years that's available, so yeah, it's pretty cool. Last thing we'll go through before we go through some resources is around the disclosure of HIV status. It's particularly important, well, I guess very relevant working in healthcare. So it's really, really important when, particularly with the stigma that still does exist around HIV, is protection of a person's privacy regarding their HIV status is really important. It is up to the individual alone as to who they want to tell and disclose their HIV status to. There's many instances where they may be asked to disclose or feel like that they're obliged to disclose, particularly with a history of a lot of, especially with legislation around HIV disclosure. But it's really important that we encourage people to know what their rights are, particularly in healthcare settings or many different settings as well, where they don't actually need to disclose. So this is from, I've got the resource on the next page there. There is booklets that are available. You can look at them online from the HIV and AIDS Legal Centre. And they go through legislation per state and look at when somebody may be required to disclose their HIV status and when they're not required as well. So as it stands, there's no legal requirements that a person discloses their HIV status before undergoing any type of medical or dental examination or treatment. Sometimes it may, there's been a lot of instances where people may have been asked questions on, say, intake forms, and I guess kind of given kind of gives the idea that they're required to disclose this, or that as healthcare providers you have a right to know. If you are using all your kind of standard kind of protocols and standard procedures preventing any kind of infections and regular standard procedures. Those are in place to prevent the transmission of any kind of risk of bloodborne viruses or other kinds of infections. So there is no risk there to the healthcare providers, and it's more important that we're protecting the privacy there of the person that we are seeing there as well, and treating everybody the same, not treating somebody differently because we know one thing about their health. It may be instances where it may be beneficial to disclose HIV status when looking at kind of drug interactions with HIV medication. But again, that is up to the discretion there of the patient too. So when we're talking about best practice working with people living with HIV, and whatever kind of healthcare setting that we're working in, is really creating that supportive environment where people can feel safe to confidently feel safe and confident disclosing their HIV status voluntarily. We're not forcing people to do this, and also that they know and they have the confidence that that information will be kept privately. It won't be disclosed. It won't be kind of talked about staff. We're not required. This information will be stored correctly. It won't be shared with other people in the community. So these are some resources that can be really, really helpful. So there is, again, HELPS. This is the HIV/AIDS Legal Centre. This was the where that kind of disclosure of HIV status information is from. So you can access this online. So you just type in HELP and you can go to the purple booklet, which is the WA, and they are updating these kind of periodically based on kind of changes in laws and legislations. This is actually a new resource that ASHM have released around the HIV testing tool for primary healthcare. So it kind of goes through the information we went through today. It's a two-sided sheet. I will actually include this in the email I'll send out to you as well. These are some different services as well that you can and resources that you can turn to for more information. So again, you can go to WAAC, you can go through our website, or reach out to WAAC if you do have any questions. MClinic as well, so again, the MClinic website, or you can also contact the STI HIV info line and speak to some of our incredible MClinic nurses if you have any questions. We can direct people to go there with their questions as well. Again, NAPOS, the National Association of People with HIV Australia, we've got some really great resources both for people living with HIV and also as clinicians and healthcare workers working with people living with HIV. They do incredible advocacy work as well in the space. Health Equity Matters, so again, the national body over of the AIDS councils in Australia. People wanting to know more information around how they can access PrEP, there's also information for clinicians too. They can go to PAN or PrEP Access Now website. It's an Australian website that has a whole bunch of information really, really useful around PrEP, everything you need to know. Again, get PEP, the site I was talking about before, to helping people to be able to access PEP. In a timely manner. Of course, many of you as clinicians would be familiar with the Silver Book, so with the STI and bloodborne virus management guidelines for WA. There's also ASHM have a whole magnitude of trainings and also resources as well, all things HIV, bloodborne viruses, sexual health, of course, as well the Australian STI management guidelines too. This will be included in the again in the email I will send hopefully later today. I have to hold myself to that now. It's been recorded. That we will include this as well. These are the contacts for the immunology departments at the public hospitals if you were needing the contacts there. Before we send through the evaluation, before we wrap up today and take questions, we'd just like to do a little bit of a plug. We have got another session coming up, another webinar in July. This one we're doing an overview of STIs in WA. So going to be a collaboration between Health Promotion and the MClinic nurses. So if you were wanting to sign up to that, I will send through the link in the email. You'll get an email through with the link for that. Again, I'll be bugging you with emails. It's not working. That's because that's not working. There we go. So I've just sent through now in the chat the evaluation form. I really appreciate if you were able to take a few moments to provide your feedback. I will stop recording now. Thank you all so much for your time today. If you have any questions, you're welcome to either pop your hand up or pop them in the chat and we can answer the questions for you. Hope you have a really lovely rest of your week. We look forward to seeing you at more WAAC sessions in the future.